Hello, I'm Dr. Monica Peak, and I'd like to welcome you to the special symposium, Bridging the Gap in Diabetes Care, Cross-Sector Partnerships to Address Social Determinants of Health Among Persons with Diabetes. Next slide. The presenters have no conflicts of interest and no disclosures to report for our session today. We have a very exciting lineup with our panel. We have 3 panelists who will be presenting today in our special symposium. First, we have Cody Wilkinson. He's representing St. Mary's and Clearwater Valley Hospitals and Clinics in Orofina, Idaho. We also have Suyana Barker. She's representing La Clínica del Pueblo in Washington, D.C. And last, we have Rachel Smith from Providence Health and Services in Portland, Oregon. The moderators for today will be myself and Dr. Marshall Chen from the University of Chicago, where we represent the National Program Office for Bridging the Gap. We'll start with an overview of Bridging the Gap in Diabetes Care, and then we'll have 3 case studies of our 3 case studies from our 8 program grantees throughout the country. These case studies will represent 3 different strategies as well as 3 different content areas in the social determinants of health for how our grantees are specifically addressing social determinants of health within patient populations who have diabetes. We'll then go into a moderated panel discussion, and then we'll have a several-minute wrap-up. So Bridging the Gap is a 5-year program that's been funded by the Merck Foundation. We have 8 grantee sites throughout the country, representing a wide variety of geography, patient populations, and payer mixes. Each site that has been selected represents a healthcare organization that is working in partnership with a non-medical organization and other healthcare organizations. And the goal is to address both medical and social factors that our patients have in an integrated fashion. As a National Program Office, we provide technical assistance. We've created a learning collaborative for all 8 sites to come together and increase their learnings. We provide a cross-site evaluation so we can learn what's working best for each of the different sites. And then we provide venues for national dissemination of our learnings so that we not only learn what's working best internally for ourselves, but we can spread this information and add to the national conversation about what's working so that we can move the needle forward and making more progress for the rest of the country on what our best practices are for really trying to integrate both medical and social needs for most vulnerable patients and to improve their health. Next slide. We have 4 main goals for Bridging the Gap. Again, the first is to build sustainable partnerships to be sustainable over time that address the medical and social factors that influence health. Second is to strengthen primary care and to really redesign healthcare systems to improve diabetes care for vulnerable populations, with a goal really to improve health outcomes and to decrease health disparities for our most vulnerable populations. And again, I'll add to that our 5th goal, our 5th aim really is to be able to provide a national platform to disseminate our findings and information so that we can be able to broadcast what we're doing here on the ground in a national forum to be able to contribute to what we know is working and some of our lessons learned for the rest of the nation. Next slide.
Thanks very much, Monica. And so I'm going to discuss 3 pillars of the Bridging the Gap program. The first is primary care transformation. All of our grantees are doing enhanced staffing models. They're all using team-based care, and many are employing community health workers. They're implementing information technology interventions, and these do things such as track patient outcomes, help perform population health management, and help identify patient social needs. And third, these innovations also address, as Monica said, holistically medical and social needs. Next slide. A key element of Bridging the Gap is addressing social needs, screening for social needs, referring patients to needed services, and addressing the underlying structural drivers of these social inequities. Our programs are screening and referring individual patients for health-related social needs. They are tackling the underlying structural social drivers of health, And they're also in partnership with community organizations establishing cross-sector programs, such as with the housing sector or with the food insecurity sector. Next slide. Another pillar is financing and payment models for sustainability. The current fee-for-service payment system does not do much in terms of addressing social needs. And so all of our grantees are pursuing alternative payment mechanisms with payers to address social needs. So for example, they're thinking about what types of pools of money might be blended into a common pool for addressing social needs, as well as thinking about the concept of braiding, of identifying separate funding schemes and sources of revenue to address social needs, to address then their patients' issues. All of our grantees are also exploring supplemental funding, such as other grants and philanthropy, to help them with their efforts. Next slide. I'll turn it over now to Cody Wilkinson from Idaho.
Hello, everybody. My name is Cody Wilkinson. I'm from St. Mary's and Clearwater Valley Hospital in Cottonwood, Idaho, and Orofino, Idaho. I'm really sad to not be in Birmingham making this presentation, but I'm glad that we're able to do this virtually. I work at a Frontier Integrated Health Organization made up of several hospitals and clinics. We are set in Frontier, North Central Idaho, and the focus of our project is on low-income rural patients with type 2 diabetes. So if you look at a map of Idaho, you can see our service area encompasses Lewis, Clearwater, and Idaho County. It's approximately 28,000 people in the area the size of Maine. However, due to the geographical factors within this region, it's approximately 2.5 people per square mile, so pretty spread out. We have 2 stoplights in this whole 3-county region, and our system is made up of 2 hospitals and 8 satellite clinics. So this is a zoom in of the location of each of our hospitals and clinics. If you see the red stars, those are our 2 hospitals, and each of the 8 blue dots are our clinics, outreach clinics, where we provide primary care services throughout the region. You'll see in the bottom right corner, Elk City. That's approximately a 2-hour drive from Orofino, which is in the top left corner. So it's a large geographical area that we cover, lots of rivers, mountains. So it's a lot of geographical barriers that we have to overcome when we're thinking about providing these primary care services to our communities. So this is a picture of Orofino, Idaho, just to reiterate the mountains, rivers, the geographical barriers that we encounter and the different factors we have to consider when we're implementing these services. So at St. Mary's Clearwater Valley, we have a very robust community health worker program. It's been instated for probably 4 or 5 years now. And the main goal is to get out into the communities and provide services to the people where they are. A lot of people, due to different social determinants of health, travel barriers, financial barriers, aren't able to access our services like they would in a conventional manner. So what we do is we send our community health workers out into the community. They go to fairs, they go to community events, and they provide free medical services, blood pressure screenings, heart rates, A1Cs, fit tests. We do mood testing with the PHQ-2s, BMIs, and then we also screen for social determinants of health. Throughout these programs, we also provide a lot of services and information. Also in Idaho, we have a very, very progressive and robust Idaho food bank. They are throughout the whole state of Idaho. They do a phenomenal job distributing food throughout the state to those in need. So when we were thinking, how can St. Mary's Clearwater Valley as a hospital organization best tackle food insecurity in our region, we thought, let's partner with Idaho Food Bank. Let's co-locate our community health worker services with those of the Idaho Food Bank and provide these screenings at their events. The goal of this partnership was to increase the community health worker access to those less likely to access healthcare. A lot of people that attend the food banks and the food distribution sites may not be attending the rodeos or the fairs that go on throughout our region. So it subjects us to a whole new subset of population that we may not be reaching otherwise. That'll be more screenings. more opportunities to identify medical and social needs throughout our communities. And then it would generate more referrals and get more information and resources distributed to our communities. So why did we pick the food distribution sites? Well, the Idaho Food Bank is a trusted resource for all of our community members. They've been in all of our communities for several years. They're well attended. The people that work at these are trusted members of the community. So it's already an established resource that people are familiar with. And the Idaho Food Bank shares the same philosophy that a lot of healthcare does. Food is medicine. We don't want to wait for people to come to the ER. We want to get out there and get people healthy so that they don't have to come to the ER when things have hit a critical status. And our goal is take our service to the people. That's also the Idaho Food Bank's philosophy. Get out there where the people are and take the services to them. And just getting people food is not the only answer. Educating people about the right types of food and how to take care of themselves through the food choices that they make, and to provide health care, not just medical care. Some of the barriers we encountered is the time to develop the relationship with the food distribution sites. A lot of these sites are only open one day a month. They are staffed by different volunteers, so it may not be the same person every time. A lot of them have different food distribution models. Some are drive up, where the people don't get out of their car. The food distribution people will actually go to their car, throw the food in the trunk, and they'll drive off. So establishing relationships with people is hard when you have a drive up model. And then organizational vulnerability. All of these, well, I shouldn't say all, but most of these sites are staffed with volunteers. So finding people to staff them, having the resources and the financial resources to keep them going is always a challenge as well. So, and then the resident distrust in the health systems. A lot of people just don't like organized medicine. They don't like organizations. They don't like the government. They don't. There's a inherent level of distrust there that we are finding is becoming a barrier. It has been a barrier. So having them actually come and access our different services has been a problem in the past, and it continues to be one. So the community health workers, it's really important when we hire a community health worker that they actually come from the community that we want to base them in. So if we need a community health worker in Grangeville, we hire somebody from the Grangeville community. It just helps to overcome that distrust. They're a recognized name in the community, and they know the resources available in that community. They know the events, and they know how to best reach the most amount of people. And then with the Idaho Food Bank, it's a great partnership. Things are going really well. We have a shared commitment to getting out there and meeting the people where they're at and helping them where they're at and getting those services to them. The Idaho Food Bank has been putting on we're calling it a road show, for lack of a better term, where they're going around the state of Idaho and they're providing education to the different food distribution workers and to the patrons of those food distribution sites to make sure that they understand the food is medicine concept, make sure that they know that there are measures they can take into their own hands to take care of themselves. And with that, I believe that's my last slide. I'm going to turn it over to Suyana from Washington, D.C.
Thank you, Cody. My name is Suyana Barker. I'm the Chief of Programs and Community Service at La Clínica del Pueblo. La Clínica is a federally qualified health center in Washington, D.C., who is serving the immigrant Latino community since the 80s. For you guys don't know exactly what is the Latino community in D.C., we are a community that's mainly composed by the Central American immigrants, different than other states in U.S. The clinic was, in the beginning, a free clinic with volunteers to help people that were fleeing the Central American War in the 80s. And we had partners to help us to build what we are today. La Clínica now has 2 clinical sites that provide primary care in mental health and substance use, and 3 safe spaces where facilities that help people to come in and enjoy some activities without necessarily having to have a doctor's or a therapist appointment. So it's just a place where people can come in and learn how to prevent some health problems and also getting involved in our health promotion activities. Next slide, please. La Clínica is fairly small as a federal qualified health center, and our biggest what we are unique as is because we provide culturally and linguistically appropriate healthcare for the Latino immigrant community and also for a special population of the community. We are LGBTQ affirming healthcare facility, and also we have a group of women who are survivors of gender-based violence that we also have a special program from them. The partnership that I'm going to be sharing with you guys today here is a partnership with CARECEN, which is a resource center for the Central American community where La Clínica was in the beginning. La Clínica was born with CARECEN. CARECEN is providing support for the refugees since the 80s, and also with all the waves of migration and different problems, CARECEN keep being the resource center, and also nowadays a legal provider, legal service provider. When we decide to start creating what we call a medical legal partnership, we thought that one of the best partners that we could have was a partner that would provide legal services. We're talking about immigrants, and we're talking about a population that has a lot of violation of human rights and civil rights. And many times for you to be calm enough to take care of your health, you need an advice from a lawyer. If your rights are not being violated or something that you're dealing with the day-to-day is not going to end up in court, what comes people the most is a lawyer. So the cross-sector partnership that we had, besides others that we have, but legal services and creating a magical legal partnership that understand the immigration issues, not only civil right issues, was very important for us. So, and CARECEN is our partner. We've been writing and investigating and having incredible good partners like the University of Chicago now that are with us understanding that immigration status is a social determinant of health, or at least is a structural barrier that every time that you try to find solutions for the social determinants that impact your health, if you're considered not a citizen, then it's a problem to access services. So immigration become an important barrier when you think that you can diminish the social determinants. So only with the capacity to understand immigration issues, and we're not talking about undocumented immigrants, we're talking about lawful immigrants in this country that cannot access services that diminish the barriers to achieve healthcare. So our partnership is based on that. What we've done is, even if we're having this long relationship with CARECEN before, what we're doing now is formally tracking clients who refer to them and the impact on their health, and how when they have to care for their chronic disease and the diabetes, having the support of a lawyer help them also to feel more supported and emotionally stable to move with their treatment. The next slide, please. The incredibly big barrier that we found in the beginning was really funding, right? It's not easy to fund legal services. Legal services is expensive. It's not easy to fund legal services when you need immigration issues or immigrant law on that too. And we had to do a lot of partnership with CARECEN to enhance funding for CARECEN. So in order to us to have capacity to have a good partner, we had to do actually advocacy campaign together to make sure the city of DC would enhance funds for legal representation. And the goal of those partnerships is establish or adjust people's immigration status. A lot of people have immigration status that could be adjusted, and they are not just because they don't have a partner or they don't have a lawyer to do that. Next slides, please. The facilitator was really the advocacy campaign. We had fun to do that because it was not only for CARECEN, but with other members of the community who provide legal services. And the whole advocacy makes our partnership stronger. Next, please. This is us advocating, and was able to, on the city, when we advocate for that, we had the priority of the city become immigrants, and you can see the slides on the projection. When you think about the budget in DC, what you think, and we had the word immigrants big on the screen. And I'm going to now invite Rachel to come and present to us too. Thank you.
Great, thanks, Suyana. Hello, my name is Rachel Smith, and I work for Providence Health and Services, which is part of the larger Providence St. Joseph Health Integrated Health System. Providence Health and Services in Oregon represents 8 hospitals and over 150 primary care and specialty clinics and a health plan. For this work specifically, though, we're really focusing on 3 clinics in and around the Portland metro area. We have multiple stoplights, unfortunately, unlike Cody in our area, and we cover about 20 square miles for these clinics. And one's in a really dense urban setting, one's in a lot more suburban setting, and one's in kind of a mix. It's right on the Portland metro area. It's a little more dense, but still a little bit more suburban. So a mix of a population, but we really wanted to focus on low-income patients living with type 2 diabetes, specifically those who have Medicaid insurance and are uninsured. So one of the big areas that we focused on with this work and more generally within Providence is a partnership with Impact Northwest. And Impact Northwest is a social service agency that's been serving this Portland metro area for over 60 years. They have a wide range of services from housing to youth development, career opportunities, to seniors. They always say they serve people from 0 to over 100 years old. So really wide-ranging array of services that they can provide. In 2015, we developed this program co-managing this partnership called the Community Resource Desk. It essentially co-locates Impact Northwest staff full-time at our Providence clinics and hospitals to be able to assist people navigate various services. We already know that the healthcare system can be really complex, but the social service world can as well. And if you're dealing with anything from a disease diagnosis, a housing eviction, a wide array of things, it can be hard to focus on one or the other or know where to go. So our resource specialists really are meant to help people identify what needs are their priorities in their life and connect them to essential services either that they can provide or in the community, and really trying to make this as part of our care team as much as possible by having them on site. The Community Resource Desk is really focused on a couple of fundamental principles. Of course, we want to connect to resources as much as possible, but we also know that education and empowerment of our patients and our clients are crucial. This program is open to patients as well as the broader community at large as well, and really centers on rapport and trust building. We cannot provide the fundamental services and support for individuals if we don't have their trust. So we really use active listening, trauma-informed principles, really keeping it person-centered. So evaluating each case as specific to that individual based on what they want, what's going on in their lives, their situations, where they live, everything that we can do to customize it to them, guaranteeing the greatest chance of successful connection. We then really have individualized action planning. So again, depending on what their income is, what is their preferred language, their race and ethnicity, so we can provide cultural and linguistic appropriate services, as Suyana was just talking about. Also making sure that we're going to be geographically sensitive. We don't want to send somebody like 10 miles or even sometimes 2 miles away, because that can be a difficult barrier for them. We can also then provide supports for a range of things, really identifying what is the individual's priority, making sure they're going to qualify for services, and helping them understand what they need to bring to an appointment. So if somebody's going to go to a food pantry, they can know what it's going to look like when they walk in. Here's the type of materials you need. Here's what they're going to ask you. Here's how often you can access it. Or for utility assistance, we'll know if they get funding at an organization, say the 3rd Wednesday, and telling clients to call by 10 a.m. because sometimes that's when they're out of money by 11. So really trying to make sure those successful connections are there as much as possible and having a face or a voice at these other organizations to go to, that they're just not one in a sea of other people reaching for services. We also provide follow-ups, so after we provide that initial intake and coordination, they also reach out at 7 and 30 days after to see, were they able to get connected to resources? If not, what were the barriers they were encountering? How can they work to break those down? Or sometimes needs can change a lot in a short time. So potentially restarting this process of what a new need or a new priority is in somebody's life. We decided to co-locate these services rather than just send them to Impact Northwest, again, an existing organization, because we heard from our direct frontline caregivers that they did not want to screen and identify a social need if they couldn't address it. And based on this survey that we did, we asked about a couple of different strategies that we could do. And over 60% said that they wanted co-located direct relationship with a social service agency organization who could provide these needs. And we also talked to a lot of our social workers and case managers, and they felt like this could be a great complement to their services. So really augment them and make sure we weren't replacing anybody existing on the care team. We also knew that we had started with doing food insecurity screening since 2013. And while it was a great proxy for other needs and helped us identify other needs that people were experiencing as well, it didn't always capture everything. We knew that sometimes it could, but it wasn't everything. So we really decided that we wanted that real-time, in-person, culturally responsive resource. All of our staff speak English and Spanish, which are the two top language needs in our area. So we decided that we wanted to do this and focus on all needs, not just one. Next slide. So some of those barriers that we encountered were getting a community-based partner integrated with a care team is fantastic, but can also be a challenge. We wanted to intentionally make them still part of their home organization, Impact Northwest. And because we weren't all one Providence system, sharing information was sometimes difficult. We couldn't even answer a simple question like, did somebody get signed up for insurance if we didn't have that release of information? They also weren't a HIPAA covered entity, so getting them integrated into our electronic health record system and improving that connection took over a year of work, really advocating for why that was needed. So those could really limit their kind of integration with our care teams a lot more. So we worked to get them integrated into daily practice and get identifying social needs as a priority that our clinicians could do. They knew it was important, they saw the value, but there's obviously a lot of expectations and priorities for other metrics and incentives that get reimbursed for. And social determinants is starting to move in that way, but it hasn't always. So really just getting it part of the daily practice rather than an ad hoc basis has been something we've worked on for several years. And offering a variety of workflow options. We want to keep it as open, as available as every clinic will work for them, will work for clients and patients. But sometimes not having one or two ways can make it difficult for tracking and communication as well. But I feel like we've really worked strong to build this partnership, build the importance, not just with our clients and patients, but with our clinicians. One quote we heard from a provider was, "I finally feel empowered to focus on medicine because I'm confident that I have somebody more expert than myself and our overwhelmed social workers who is able to find resources for our patients." So we've heard that it really allows them to, rather than focus on that in the moment, when sometimes it doesn't feel like the skill set or the expertise of our clinical staff, that having this partnership makes them feel like they can focus on continuing to take their blood pressure, but then also explaining that when you're done with your appointment, we have somebody we can talk to, so they can still hear and respect their patients in that way and care for them beyond their clinical skills as well. Also, as I said, there hasn't always been a requirement to do social determinant screening or connection with community partners or others, but a lot of initiatives funded by things like CMS through comprehensive primary care, patient-centered primary care, medical home are really increasingly doing this. So having that cohesion and connection to satisfying other requirements also makes it a lot easier for our clinical teams to be able to prioritize and do this work. And open communication and shared decision-making with all of our teams have been useful, from being transparent with our clinical teams to why we're doing this work, how we're doing this work, and even sometimes barriers so they can understand we're working towards it, but also making decisions from what kind of needs are we going to address, where are we physically going to be located with Impact Northwest, with our community partners, has really created this shared ownership and belonging that I think makes the program as strong as possible. And with that, I'm going to hand it back over to Monica and Marshall for some questions. Thank you.
Thank you very much, Rachel and Sienna and Cody, for 3 wonderful presentations. So the next half hour or so, we're going to engage in a panel discussion where Monica and I will be asking the panelists a variety of questions for them to answer. And so the first question is for all of you. And I can imagine a lot of viewers saying, my gosh, these are wonderful programs, very impressive, they sound great, yet how am I going to get there when I'm starting from scratch? So the question is, what advice do you have to organizations that would like to replicate your programs or develop similar programs, but are starting from scratch?
I would say gather as much information as you can. That seems obvious, but I think having multiple stakeholders' perspectives is really important. Again, we gathered information from our direct frontline caregivers so we could see what their needs were, what their expectations or wants or struggles were as we developed this. We also talked to leadership about what they wanted to see in various elements. So I think gathering those multiple perspectives and valuing what our partners could provide, not just what we wanted them to. So really forming those expectations and trying to work together to one place. It was really a crucial step to figure out how to do the work.
Yeah, and I would just echo what Rachel said, because getting stakeholder buy-in is huge. I mean, you can't move forward unless everybody understands why you're trying to do what you're trying to do. Go to the providers and say, social determinants are hindering patient compliance with medications, or go to management and say, we can get better outcomes if we can get in front of social determinants. So as long as everybody's on the same page with why you're trying to do it, I think it's a lot easier to take that first step.
Yeah, I would add that I think a little bit what Rachel said at the end, right? The doctors finally said, I can do my medicine here because I know who else is doing the other part. I think this teaching or kind of bring examples of how important is partnership, like an intersectorial partnership is fundamental to do the work that we are doing. We cannot do anything on the medical side or with the medical perspective, but when we add partners and we have people around us, makes everybody's job better. I think the bringing, and I think sometimes organizations do that already on the ground. That is not an official program, just the relationships that you have. So I think it's interesting to map that, to build on that instead of bringing something completely new, assessing how already some connections happens and use that to enhance that kind of connections that exist and make this more formal. This is one advice that I would give. Like a lot of organizations, especially frontline people, they have best friends who help them out sometimes. So if you build on top of that, it's much easier for people to recognize the importance and make this a more organized system of understanding the partnerships and the need for intersectorial partnership.
Yeah, thank you. I'd like to follow up on the point that all 3 of you made regarding buy-in. And you can think about a variety of stakeholders, including the clinical providers, the frontline staff, and the leadership and management. Can you give any examples from your programs of the types of arguments or points you would make that appeal to the different stakeholders?
Well, out here in rural Idaho, we're one of the only entities where people can turn to for resources. So we do a lot of programs and whatnot because we're the only ones that can do it, and it's the right thing to do. We don't always make, break even on all of our programs, but you can't take care of a community and you can't have true community health if you're just picking and choosing. So I think having the argument that attacking social determinants of health is a whole department in itself, and you have to think of it separately, but how it also integrates with the work you're trying to do as a whole. You can't do your work, and you can't be an effective healthcare entity if you're not out in the community trying to be doing those preventative things. I don't know, Rachel, what do you think?
I would completely agree. I think really just emphasizing how we're doing it was crucial part of it. And sometimes it was also just explaining that we had a shared mission, even if it wasn't in those words. Both our clinical teams and our community partners have the same goal of making our communities the healthiest, happiest places that they can be. And we just sometimes went about it in slightly different ways. So it was often explaining that, you know, social services can provide this part of care and healthcare can provide this part, and together we can more cohesively care for the whole person effectively.
And when we think about diabetes being such like a great way to do that, because you need really people eating well and eating healthy so you can really deal with diabetes, right? We know that only providing healthcare in a sense doesn't help, or we see like sometimes when people understand like food as medicine, how the whole management of the disease get much better, right? From the point of view of the provider too. So I think diabetes is giving us this incredible example of how much we need a system who protects people and helps people to change habits and to be healthier. And that support is fundamental to add into the having access to healthcare. So I think this has been interesting for us to have the partners and people understanding what is the connection between the way that you live and work as the way that you're going to have your health. So this project has been incredibly good for that.
Yeah, and I'll add on one more thing of also thinking about higher level stakeholders outside those who are maybe on the ground or caring for patients. I think it was also important for us to talk about how this was part of our mission and our history. So Yana talked about the partner with CARECEN being really a part of who they were from the beginning. For Providence in Oregon, we've been in this community for over 160 years. And as a Catholic-based system, we were actually started by nuns. And there's a big statue at one of our hospitals of Mother Joseph. And we always emphasized her hand is outreached and she's holding a basket of bread, not a scalpel. So that social needs was a part of our foundation and our history as far back as, you know, over the 1800s. So even though it looks different now, just coming back to the roots of why we are an organization and how we do it as we are, I think is really crucial also for leadership and stakeholders at a higher level than in the clinics.
Thank you. So I'll pass it on to Monica for the next question.
Excellent. Each of you touched on the importance of trust and to some degree how either mistrust with the broader societal environment or with healthcare institutions or the government plays an important role with the patient population that you're trying to serve. Rachel, you talked about how it was important to sort of listen to your patients. And each of you have touched briefly on some of the strategies that you've used to try and overcome that. I was wondering if you could talk a little bit more about the importance or how the process for trying to reach the populations and overcome some of the distrust and to work a little more effectively to build trust within those populations.
Yeah, well, the group that we serve it's actually been incredibly good for me to be part of the bridging the gap, because we know what mistrust means for different people, and is the same problem, right? When you think about when you're not understood by the organization that's trying to bring something to you, when your culture or your perception is not taken into account, it's all the same. It's funny as thinking to us as a human being. In different communities, we have the same feeling. We have the same feeling that somebody's not hearing us, is not understanding us, and many times telling us what to do with our lives without bringing us to the table to discuss if we have conditions to do that with our lives or not. So, and I've learned that different communities in my community have the same feeling, that they are not at the table when things are being decided what's good or bad to them. And how convince them later to be part of this if nobody asked them in the beginning what they think about it. So I think this whole movement about community health workers is incredible. At Latino community, we call them promotores de salud. This is fundamental because this is bringing people to us, telling us why they don't trust us, or helping us to translate or understand better the message to adapt to the reality that are living. And adjust the things that could be adjusted by us, because some of those adjustments sometimes is a structure we cannot do as a health system, we cannot do that. But bringing the possibility of people be part of the process, not just like subjects of something. So every time that you do that, you have your client as your partner, not as somebody that you need to boss around or tell what to do or not to do. The results are incredible. And we feel the trust being built by over time, not in the beginning, but over time with consistency. We are being there and show that's not just a project, it's really like the core element of the way that we live and we work. People with time trust.
Excellent.
And I also think it's easy to work on building trust with an organization as you sit around a boardroom at a higher level and you discuss, you know, motives and goals and what you're trying to accomplish. But I think it's got to be more than that. And I'm sure Suyana and Rachel can agree, but you have to get your hands dirty and actually be on all levels of the work. Some of my best days of when I've been waiting in line with some of the people waiting for the food truck to pull up and just having that conversation with them, seeing what, you know, they have to stand in the rain or whatever elements for that truck to show up. And then when they get here, help that everyone pitches in, including our community health workers and our employees, and unloading those trucks and getting them lined up and getting the food distributed and getting everybody back home and making sure everybody gets what they need. So I think you have to work on, or at least have a strategy for working on that trust from the top level all the way down to the front line, and get your hands dirty.
Mm-hmm.
Yeah, I'd really agree. And I think a big part of that is just transparency with kind of all the different groups, being transparent with our community partners about where we're at, doing it, why we're approaching things, and similarly with patients and clients. Also, it's not always going to be the information here if they don't qualify, or in the Portland metro area and around the country, housing is just very limited. So having to tell somebody that it could be a 1 to 2 year waiting list is really difficult, but not wanting to set expectations or deceive anybody in any way. So having honest conversations, I think, across all of these different areas, even when they're the difficult conversations, is a really key part of it as well.
Excellent. So transparency, partnership, and connections over time has really kind of worked for you all, it sounds like. Thank you. I'll turn the next question back over to Marshall.
So how do you address your patients' individual social needs, as well as how do you work with their food insecurity, as well as help with the community problem of food insecurity? Or how do you help one immigrant with their medical legal needs, as well as address some of the underlying medical legal issues of all immigrants in your community?
Yeah, this is a great question, right? I think what we try to do all the time is to have two levels. Like, one is the level that we do with one client, and what that client what we can build to that client with their individual capacity, perspective, resources. But also we add that to what we call all the time an advocacy component of our work. Everything that we try to enhance for one client, we try to enhance to everybody. And then you have the capacity to, at the same time that you deal with one problem and try to do the best for that problem, we try to use that problem as inspiration to make that barrier out for everybody. So the combination of using the encounters that we have, the clinical problems, the referrals problems, to kind of build what we have as an advocacy agenda, and try to be in coalition with other people, because also doing advocacy alone is really difficult, because we're not, as a healthcare organization, we are not like policymakers, right? Or we don't have the capacity to sometimes to analyze policy or to decide what is going to be an advocacy agenda. But we, in coalition with partners, we bring our voice there. And sometimes on advocacy, the voice of the medical system is very important, because the voice was going to say, this is killing people. This is killing people too soon. So we see sometimes that the voice of the clinical team on our advocacy efforts is very important. So this is what we do. We try to build individual plans, but also impact structure change using coalitions and advocating with our clients.
Yeah, I think advocacy has been a key part of this, both at a local level to get, some change in policies or approaches, but also at a statewide level. We've connected really with some of our partners to do something called Breakfast After the Bell, which allows schools to not make kids have to eat their, free or reduced lunch before classes. They can eat it in their classroom. So that was something that, again, seems as obviously something that's beneficial to health. If a child's going hungry, they're not going to be as focused. They're not going to, it affects their development. So sometimes coming at it from this health perspective and a social perspective together has been really critical. And then something fortunate for me as part of a larger integrated health system, which I know everybody who's listening to this presentation won't have that ability, but we also have community benefit dollars. So we have to make certain investments back into our communities, and our work with the community resource desks and our partnerships with Impact Northwest and others also helps inform us and give us a lot more of a voice of, individuals in these communities, a different perspective that patients can provide other than just our patient and family advisory councils, to really understand what are the needs, what are the priorities of our patients in our community, to be able to then make investments into things like, affordable housing opportunities, or community health worker, traditional health worker integrated systems with greater compensation opportunities. So having this voice from our partners and from our patients and clients allow us to also target and focus some of our intervention strategies and investments greater as well.
Yeah, and it plays into the whole, do you want to give a man a fish, or do you want to teach a man to fish? You can hand out food all day, but a lot of times we're seeing people will say, I don't know what to do with garbanzo beans, and they'll give them back. Well, giving them that education on how to cook the foods that you're giving them and using them in an appropriate way that will actually impact their health. Give them some recipes. We have this running joke where we work, because nobody in Idaho has really seen plantains before, but we're getting a lot of plantains for some reason. So finding what to do with plantains and how to incorporate them, and just having fun around the education side of things and not just handing things out. So.
Thank you. And next question, Monica.
Great. So I wanted to talk a little bit about sustainability. And so you each are doing amazing and wonderful work, and it's a challenge a lot of times to figure out how to continue this work, particularly once a major sort of thrust of funding ends. And so I know that all of you all have been thinking about ways to look for new sources of funding. Marshall had talked a bit about some of the payment, but I wanted you all to just talk a little bit more about how you're thinking about sustaining these cross-sectoral partnerships that you've been developing, and whether or not you have a planned business model in mind for trying to financially sustain these partnerships as well.
Well, I'm sure all the grantees can agree, but we're very thankful for this program and the funds that we've had to be able to support our programs to this point. Going forward, we're having conversations with insurance companies, and we're having conversations, like Rachel said, doing that advocacy work, talking to policymakers and trying to come up with a plan. I think if there was a cookie cutter solution to sustainability, we'd all be doing it. But I think it's going to be on a individual basis for each organization to make that move to start those advocacy conversations and start talking to insurance companies and see how we can make it sustainable. I don't know, Rachel, did you solve it?
No, wouldn't that be great if we could all figure it out? Perfect. Again, we look at some of this from, as I kind of just mentioned, a community benefit perspective, because it's not just something that we know is exclusively serving our patients, it's also open to the community as well. We can use some of our funds to focus on that as an intervention that ties back to addressing some of our community health needs assessment needs. But we've also been trying to start exploring conversations with what in Oregon we call CCOs, or coordinated care organizations, sometimes accountable care organizations or health organizations across the country. And they have something called health-related services, and they actually have to make investments outside of just their Medicaid members as well, and are really looking at how can they do that more in an intentional way, really aligned with the hospitals and health systems and community organizations. So collectively, it's also about exploring larger partnerships and coordination that we can do together as much as possible, and how can we serve our communities and explain the benefit that it provides. Even sometimes we've done things, one of our clinics is in a town called Milwaukee. Yes, there is a Milwaukee, Oregon, and yes, it is spelled different, because why wouldn't we do something slightly? But we've actually gone to the city council as well and talked about the benefit it has to them. So we've talked about it a bit, but trying to have, I think, stories of individuals in these communities that have been benefited, the impact it's had on them, as well as some of the data that it has clinicians, and just overall kind of our story from multiple perspectives is going to help us kind of keep that braided and diversified funding and support through multiple options and sectors.
Yeah, we are, I think we're the smallest, we are very, as an organization, very small. So we cannot do any thinking of sustainability that's not in connection with other health centers. So in DC, we are part of a coalition of different health centers that helps to think about sustainability and how to integrate now. And there's a project and how to integrate the social determinants and what takes to troubleshoot social determinants, or maintain partnerships, or refer people, or the multiple times that you have to refer until you find the right services. So we're trying to make sure we understand that, or how much cost it, or how many people has to be involved on those actions that helps people to connect with a service that would help them to diminish the impact of that social determinant. But it's a work in progress. I think the managed care organizations are interested in discussing that and understanding that, but they still think on a medical fee-for-service kind of perspective. So it's a lot of dialogue, but I do think there is a lot of people interested in this dialogue. I think there is a cost benefit on that. That's everybody's understanding. And I think finally we have everybody understanding what is around the health sector that impacts health. And more people are open for this conversation. I don't know exactly where it's going to go, but more people is open. So we feel optimistic.
Yeah, thank you. So we have time for one more question. And if you could each keep your responses to 1 minute or less. So this last question is having to do with the capacity of community-based organizations, that in some ways that there's a limitless amount of social needs of our patients in the clinics, and the community-based organization sector often is overwhelmed and has limited resources. So tell us a little bit about the capacity of your community partners, and how you can be good partners in working with these community partners, given their resource limitations and their capacity limitations.
Yeah, I think that's the unfortunate reality, that social needs are so prevalent, and especially now during coronavirus, I think that's being seen more and more, and that need unfortunately isn't going to diminish. So one way that we're really conscious of that is just staying in constant communication with our partners, making sure that we understand what their capacity is. For our partnership this way, there's a lot of different ways to do it, but we've opted to pay for the staff that we ask to be on site. So not just asking our partners to utilize, other funding sources or other opportunities, but really coming alongside them and supporting these positions, and also trying to provide, opportunities for funding, or however we can, or sometimes even just writing letters of support on behalf of them to other grants that they can apply to and funding opportunities. So kind of constantly seeing what is it that they need, what is it that they're seeing, how is it that we can be a partner, not just in advocating for large change, but also advocating funding support or opportunities for them in the larger community as much as possible across, the different sectors, or even, again, national grants that they're receiving that we may not be directly a part of, but we know that we can explain the value of the service that they provide.
Yeah, I would say the same. I think Rachel said everything, like join people on their issues too, not only ask them to join on your requests, right? I mean, make sure you're part of the network and the people can get help from you. This is helping us to help other organizations to keep afloat. And on this COVID time, our organization so far is around 25 new grants that we had to put together. And we participate in around like 13 other community members, other organizations who need to have these funds coming. It's a tragic times. Our community has been heavily hit as other minorities, and has been incredibly important to have all the partners with us going together to find solutions for what's going on right now.
Yeah, and I can only echo what Suyana and Rachel just said. Social entities in rural communities and rural organizations like ours were already strapped before February and January hit. And I mean, the need to work together and to strategize and to find solutions together is more important now than it ever has been. We thought we had great programs to try, and they're all based on getting out in the communities and seeing people. And now we're shifting gears again just to respond to the current state of things. So constant communication and constant strategizing and keeping the main goal at the forefront. I mean, that's all we can do. So I can only echo what Rachel and Suyana said.
Excellent. Thank you all so much. This has been an incredibly helpful and informative session. We really appreciate you all sharing your insights. I think it's interesting that despite the tremendous heterogeneity in your location, from a very urban to frontier to a site that's spanning multiple states, to the kinds of patient populations that you're serving, to the regions of the country, and to even your tactics. So again, one of the questions that we're thinking about nationally is, as we're integrating medical and social needs, where is the best place to do that? So Cody, you have taken community health workers and embedded them within a non-medical facility, a food pantry. And then Suyana, you're working in partnership with an existing organization that is physically separate from yours, but close by, half a block away. And then Rachel, your team is actually co-located within the healthcare system. So your team comes in with their desk, their community referral desk, and sits within the medical organization. But there's still, despite all of these differences, several common themes that are coming up around engaging stakeholders in an ongoing way, having leadership buy-in from the very beginning, and being constantly sort of driven back to your core mission and vision around serving patients and thinking about the primacy of their social needs and how they're driving their health outcomes. And so I think that despite the differences of place and space, that there are a lot of common themes that are bringing your work together, that bring all of our grantees together, that make the work that you do important for the rest of the country to learn from. And so I really appreciate the time that you all have taken to share with us today. And I'll just ask if you each have 15, 20 seconds of any parting words that you want to share with all of the people that will be watching this special symposium.
I can go first. I think the most important first step is just to take that first step and make the phone calls, find out who in your communities are already doing the work that you want to accomplish, and align with them, and don't try to reinvent the wheel. Make that first step and make that first call.
Absolutely. Thank you. Don't be afraid. Just do it. Suyana?
Well, we have to fight poverty and we have to fight racism. we cannot do this without fighting those two issues. So we have to find why some people are leaving to be poor and how are we discriminating against people. If we find those two things and we find the partners to help us to understand that, we can deal with the rest.
Mm-hmm. Addressing the root causes of the disparities we see in health. Absolutely. Rachel.
Yeah, I would say absolutely what Cody and Sienna said. Just even though it can feel hard and outside of the scope of sometimes what, on the healthcare side we were trained to do, I think, again, coming alongside our partners, really meeting our patients where they're at, caring for them in this more holistic, comprehensive way is definitely it. So reaching out, coming alongside our patients and our partners in our communities is absolutely our mission and how we can do healthcare better.
Yeah, and so we can all do it together. So it's tough, but we can do it. I'm holding hands together. I really have been inspired by this past hour, and I hope everyone who watches this has been too. If anyone is interested in following up directly with our fabulous panelists, their emails will be available as part of the materials for today's session. And I'll leave the final words to my friend and colleague, Dr. Marshall Chin.
Well, thank you to our panelists for such an inspiring set of talks. And I think, like, to our viewership, at times we can be intimidated by the problem of social determinants and health inequities, but there's actually a great opportunity for us to make a difference now. And I think, like, we have three wonderful panelists, and my experience has been that people working in this area have similar values of really wanting to do the right thing. And so I think that all of us should feel empowered that we can make a difference, and that working together, as our panelists have said, really is the way that we can help individual patients and help our wider communities. So thank you so much for watching our panel session, and good luck to you all in this mission.